This video was sponsored by Back Specialist Hospital.
I'm Dr. Charles John Buckman, obstetrician gynecologist. We are not sure exactly how the blood pressure goes up. We have risk factors, but as to exactly why it goes up, there are only theories that we are able to tell that maybe this is the reason why your blood pressure went up. Okay, the reason is we haven't been able to tell exactly why the BP goes up, but some people have such risks. The theories that I'm going to mention are that the blood vessels in the placenta are smaller than they are supposed to be in such people who develop blood pressure in pregnancy. Usually, in the 4th month, around 16 weeks, the blood vessels are supposed to be bigger so that they can contain more blood. But in such women, the blood vessels are much smaller, and so sometimes the lining of the blood vessels become damaged. So these release some substances into the bloodstream, which predisposes them to have high blood pressure. It's difficult to be able to put it in layman's language. There are a lot of technical, so I'll just put it this way. So the risk factors, it's common in blacks. It's common in first pregnancies. If it's your first pregnancy, you are at risk of developing hypertension in pregnancy. It's common in the extremes of age. Let's say less than 18, teenage pregnancy, more than 35. And those with multiple pregnancies, twin, triplets or more, also have a risk of that. People who've had a previous history of hypertension in pregnancy have an increased risk of developing hypertension in pregnancy. And then people with chronic kidney disease could also have an increased risk of developing hypertension disease in pregnancy. It usually develops from 20 weeks. So if somebody has, let's say before pregnancy, the person was hypertensive, you won't term that as hypertensive disease in pregnancy because the person was already hypertensive before the pregnancy. So hypertensive disease in pregnancy is strictly from 20 weeks. When we see that your BP has gone up from the 20th week of pregnancy, then we say you've developed hypertensive disease in pregnancy. Now, as I mentioned, these people who have such risk factors, once the BP starts going up, it can affect the whole system from the head to your toes. I mean, blood pressure can go up and lead to a stroke. It can affect your heart failure, can affect your lungs. You may have fluid in your lungs, can affect your liver. So the liver is not able to function well. And then sometimes they bleed into the liver. It can affect your kidney. And so with that, they produce a lot of protein in the urine. So it's one of the cardinal things that we'll check. If your BP goes up, we'll check your urine to see if there are proteins in it. If there are proteins in and it's high, then tells that your BP is really affecting you. Sometimes that may be the reason why we may have to deliver the baby. In such circumstances, we'll consider you more than the baby, no matter how advanced you are in the pregnancy. We've had to deliver somebody around 22 weeks. We know the baby won't survive, but we had to because you have to consider the mother, because otherwise the mother could die. She could live to develop to get another baby, but as for the mother, when she dies, she's gone. So sometimes you have to make such unfortunate decisions. It can affect the bone marrow, so it makes they are not able to produce enough of the blood components. So this is some of the things that can affect somebody with hypertension disease in pregnancy. This is the 3rd stage of labor. So the first is from 0 dilatation to 10 centimeters, as we talked about, when the cervix is fully dilated. Then the second stage is when from the baby, the cervix being fully dilated till the baby is born. That's the second. Then the third is when the placenta is fully delivered. Now, so if you have a retained placenta, usually you will wait for about 30 minutes for the placenta to be delivered, up to about an hour. Sometimes you can even wait up to 2 hours, provided you are not bleeding. If you are not bleeding excessively, we can wait till 2 hours. If after 2 hours the placenta hasn't been expelled, then probably the uterus is not contracting well. So usually with that, you can set up some drug called oxytocin. It will help the uterus to contract and get it out. Sometimes you can actually inject the oxytocin into the cord itself. So it helps the placenta to buckle sort of, and then it's delivered. Sometimes we may have to manually get the placenta out. So with that, you wear a lung glove and then follow the cord so you get the placenta and then you deliver the placenta. Placentas really are retained, especially in, let's say, miscarriages after 20 weeks, between 20 and 28 weeks. Usually it's the uterus is not able to contract well, so most of the time placenta sometimes may be retained. So with that, oxytocin helps to get it out. The other reason may be that the placenta is morbidly adhered. So with that, the placenta, instead of, well, it's attached to the uterus all right, but it shouldn't have, as in grow into the uterus. Sometimes the placental tissue grows into the muscle itself. So sometimes it can go all the way to the back of the uterus. So if, let's say, the uterine wall, there's the inside, which is the endometrium, middle layer being muscle, outside being the serosa. The placenta can travel all the way to the back, the serosa layer. Okay, so with this, the placenta is morbidly adherent to the uterus. You can't remove it. Even with manual removal, you can't do it. So with that, sometimes you can actually leave it. If it's morbidly adhered, you can actually leave it. And then we can give some medications called methotrexate. It will help sort of destroy the placenta, and then eventually it will come out. If the patient is bleeding seriously, sometimes it's not the usual, though sometimes you may have to get the uterus out, as in do a hysterectomy if you have to. And you can't remove the placenta, you may have to remove the uterus, yes. Sometimes I think it's more because sometimes we have to wait for lactation to start. Usually when you give after delivery, you give the baby to the mother for the baby to start suckling. Now with that, it releases some hormones which help the breast milk to start flowing. Okay, so but once the baby is not suckling, the hormone is called prolactin. It will not go up for the lactation or production of milk to actually be established. So sometimes some women, especially those who don't breastfeed frequently, you will not have enough breast milk because the baby is not suckling to produce the hormone that will help lactation to be established. Some women too naturally don't produce enough milk. The baby could be suckling but the milk is not enough. So with that, we may advise that you top it up with formula feeds, but that is a natural phenomenon we can't do much about. There are some medications that help. Metoclopramide is known to help with the production it helps to help some of the women to produce more breast milk. Yeah, but basically that's it.
This video was brought to you by Back Specialist Hospital and Fertility Center.